Welcome to Module 9 of EHAD's e-learning programme. And today we're going to focus on the peripartum management of women with von Willebrand disease. My name is Dr. Michelle Lavin, and I'm a consultant haematologist based in the National Coagulation Centre, St. James's Hospital, Dublin. Today in this module, we're going to first focus on a review of the state of the art in this area, followed by cases and the most recent evidence to update our clinical practice. So part 1 will focus on the state of the art for the management of women peri-delivery who have von Willebrand disease. And this is certainly a complex situation because even in the normal population, plasma von Willebrand factor levels will increase significantly throughout pregnancy. And this is due to a combination of increased von Willebrand factor synthesis and reduced von Willebrand factor clearance. And among women with von Willebrand disease, there may be variation in responses, but the majority of women will have low von Willebrand levels or mild type 1 von Willebrand disease. And an increase in plasma von Willebrand factor levels can be seen as early as the first trimester. We can see here that in normal pregnancy, there will be a simultaneous increase in both antigen, activity, and factor VIII levels during pregnancy. However, depending on the type of von Willebrand disease, responses in women with von Willebrand disease will be more heterogeneous. I've summarized the changes seen commonly here in this table. So for women with plasma von Willebrand factor levels between 30 and 50 IU per deciliter, or those with low VWF, will be expected to increase to within the normal reference range. And although we commonly use the term normalization, I'm going to discuss how this may not accurately represent this change. For those who have type 1 and baseline levels less than 30 IU per deciliter, there's more variable responses seen, and some may fail to increase in pregnancy. For women with type 2 von Willebrand disease, although there may be an increase in von Willebrand factor antigen, the dysfunction in the protein is still present, and there'll be a failure of the functional defect to correct, and may in fact have worsening of thrombocytopenia for those with type 2b von Willebrand disease. For those with type 3 von Willebrand disease, there will be no change during pregnancy. When we look at whether clotting factor concentrates will be required at delivery, they may be required in some patients with type 1 von Willebrand disease who fail to increase, particularly if they're non-responsive to ddAVP. They'll likely be required in those with type 2, and they will be required in those with type 3 von Willebrand disease. And all women should be considered for the use of tranexamic acid postpartum. So how do we manage women who have known von Willebrand disease when they're pregnant? Well, this should actually start before a woman is ever even pregnant. From their very first encounter with the Haemophilia Treatment Centre, they should be advised that they should alert their treatment centre if they are pregnant in the future. They should also be made aware that hemostatic cover may be required for some fertility treatments and be provided with genetic counselling if there is a pathogenic mutation identified. They should be aware of the bleeding risk that can be associated with pregnancy and discuss this with women in order to allay their fears or concerns. And antenatal care should always provide a combined approach with the obstetric team. And we mentioned earlier that women with type 1 von Willebrand disease will increase their plasma VWF levels throughout pregnancy. And we commonly will refer to this as a normalization. But you can see in women who have von Willebrand's disease versus healthy pregnant controls that the plasma VWF level changes mirror that but remain significantly lower than patients who are healthy without von Willebrand's disease at all time points peripartum. So we have to be cautious about using the term normalization because they will increase, but not increase to within a normal, healthy pregnant woman's range. And despite this increase, postpartum hemorrhage may still occur in women with low VWF or mild type 1 von Willebrand disease. In the LOVEC study, PPH was self-reported in 63% of Paris women, and excess bleeding still occurred in 21% of deliveries following a diagnosis with combined care provided in their subsequent pregnancies. For women who have type 2 and type 3 von Willebrand disease or severe type 1 VWD, they will require intensive monitoring postpartum in order to ensure adequacy of factor levels. So we would recommend delivery in a centre with high-risk obstetrics, which is allied to a haemophilia centre and can provide laboratory monitoring. All women with von Willebrand disease should have monitoring of plasma von Willebrand factor levels antenatally, and this includes at booking in the early third trimester and prior to any invasive or diagnostic procedure. It should include a platelet count for those with type 2b von Willebrand disease and factor VIII levels for those with type 2N. Throughout the antenatal course, there should be a shared decision-making approach with the patient in which they're informed of all their options and the risks and benefits of each choice. Most women with von Willebrand disease will not be on prophylaxis prior to pregnancy, and pregnancy in itself is not an indication for the use of prophylaxis. But they will require hemostatic cover if their levels remain low, and they require invasive testing such as chorionic villus sampling or amniocentesis, if they undergo a surgical termination or they have excess bleeding with miscarriage, or they experience antepartum bleeding. It is important that women ensure obstetric investigations for antepartum bleeding are completed, and it is not assumed to be related to their underlying bleeding disorder. At the time of delivery, it's recommended that for those women who have reduced levels, they receive treatment in order to increase their levels for 3 to 5 days post a normal vaginal delivery, or 5 to 7 days post a normal cesarean section. In women with more severe disease, this may need to be prolonged further on an individual case-by-case basis. The need for treatment will depend on their VWD type and subtype, their current plasma VWF levels in the third trimester, and their bleeding history. Planning a delivery is the most critical component of antenatal hemostasis care, and we have to ensure that all people involved in the care of this baby and infant receive a copy of a plan, and this should be provided early in the third trimester, as babies may sometimes come in advance of their expected due date. I would recommend clearly documenting the following on every antenatal plan: the suitability for neuraxial anesthesia, such as spinal or epidural. The current guidelines, the 2021 ASH guidelines, have suggested targeting a level of 50 to 150 IU per deciliter over a higher activity level to allow neuraxial anesthesia. But importantly, don't specify who is suitable for the use of neuraxial anesthesia, stating it's a complex decision outside the scope of these guidelines. A recent international survey of haemophilia providers asked what thresholds would be required in order to ensure suitability for neuraxial anesthesia, either a VWF antigen greater than 50, an activity greater than 50, or both greater than 50, or that it was not permissible based on VWD type. And you can see there's quite a variety of responses seen here, and there was a split between North America and Europe, with many more European providers favouring that in type 2 patients that neuraxial anesthesia was not permissible. The RCOG guidelines recommend for patients with type 1 von Willebrand's disease, where the activity has normalized by pregnancy or treatment, that central neuraxial anesthesia can be offered. For patients with type 2, that it should be avoided unless the activity is more than 0.5 IU per mil or 50 IU per deciliter, and the hemostatic defect has been corrected. They note that this may be difficult to achieve in type 2, and it should not be given in cases of type 3 von Willebrand disease. And there remains a concern that although we can correct a plasma von Willebrand factor defect with the infusion of concentrate, platelet VWF levels are unaffected. Of course, for those who have type 2b, the adequacy of platelet count should be ensured, and for type 2N, the adequacy of factor VIII levels. It's easy to forget that it's the importance of levels not only at catheter insertion, but also at catheter removal is essential. So it must be communicated clearly to hospitals that levels must be corrected prior to catheter removal, as the bleeding risk is present at this time as well. So we should clearly document the suitability for neuraxial anesthesia. The mode of delivery should always be based on obstetric indications rather than hemostasis. And we should state if upfront hemostatic cover is required, or what the plan would be in the event of bleeding should it occur. It should be clear to the hospital who they should contact in the event of bleeding and what those contact details are. If fetal precautions are required, this should be stated clearly. And what we mean by fetal precautions is an avoidance of fetal blood sampling, external cephalic version, fetal scalp monitoring, ventouse or mid-cavity or high forceps. And whether cord bloods are required should also be stated. These fetal and cord blood requirements are usually in babies who are at risk at type 3, type 2, or severe type 1 von Willebrand disease, and are not normally required in babies who are born to mothers with milder VWD. So here is a short summary of the different approaches regarding hemostatic cover at delivery. For women with type 1 von Willebrand diseases who experience an increase in pregnancy of their plasma VWF levels, they may not require any prophylactic treatment prior to delivery because their levels have significantly increased. However, for those who have type 1 von Willebrand disease who have not increased with pregnancy, or type 2 or type 3, they will need treatment to increase their levels prior to and following delivery, which is usually in the form of clotting factor concentrate. DDAVP can be used, but should be avoided in the setting of preeclampsia. There is a risk of hyponatremia and seizures, so fluid restriction must be employed. They should use it can be considered in peri-delivery prophylaxis for patients who are responsive but have failed to increase their levels in pregnancy. But it's not normally used in the setting of postpartum hemorrhage due to the fluid restriction requirements. The safety of DDAVP in pregnancy has been reviewed and is certainly brought up frequently by our obstetric colleagues as a concern. But a systematic review of 30 studies of use of DDAVP in pregnant women with a variety of bleeding disorders found that when it was used in early second trimester or first trimester procedural-related prophylaxis, there was no bleeding in 50 pregnancies or adverse events. In 172 pregnancies in which it was used for peripartum hemostatic cover, there was no bleeding complications in all but 5 deliveries. These 5 pregnancies, only one had von Willebrand's disease, the other had storage pool disorders or Ehlers-Danlos syndrome. In 29 of the 30 studies, there was no significant adverse events experienced. A single study reported a case of seizure with repeated DDAVP use and hyponatremia, and one case of premature labour where a trial of DDAVP was employed at 36 weeks gestation and the lady proceeded to premature labour. So although we have now discussed that these patients will require treatment at the time of delivery, the threshold for treatment is not in fact addressed in the 2021 VWD guidelines, despite this being a critical component of care. A variety of approaches are used in different clinical settings. Some clinicians will use those patients who have a threshold of less than 50 IU per deciliter in the 3rd trimester and will treat them to a 100 IU per deciliter or 150 IU per deciliter. Some other providers will treat those who fail to correct greater than 100 IU per deciliter and will treat to 150 IU per deciliter to minimize the risk of postpartum hemorrhage. A recent Dutch study is now looking at if VWF activity is less than 80 IU per deciliter and treating these women to 150 IU per deciliter at time of delivery in order to minimize bleeding risk. So it's still unclear what the optimal threshold is. The RCOG would recommend that maintaining factor VIII and VWF activity levels more than 50 IU per deciliter for at least 3 days following uncomplicated vaginal delivery and at least 5 days following section. But note that those patients with type 3 von Willebrand disease may require treatment for 2 to 3 weeks or even longer following delivery. All women should be considered for tranexamic acid, with the current guidance recommending that in women with type 1 von Willebrand disease or low VWF levels, they would suggest use and say that this may also apply to type 2 and 3 von Willebrand disease. It's safe to use while breastfeeding, and the concentration in breast milk is less than 1% of peak serum concentration. Again, all women require vigilance from bleeding and monitoring for secondary postpartum hemorrhage. And this is because the rates of secondary postpartum hemorrhage are much higher in women with von Willebrand disease than in the general population. And we now have a unifying diagnosis or a unifying definition of secondary postpartum hemorrhage from our recent guidelines, which is blood loss heavier than normal lochial loss between 24 hours and 6 weeks postpartum, and necessitates medical review or intervention or lasts beyond 6 weeks after childbirth. In terms of the follow-up care for women who have just given birth, plasma von Willebrand factor levels will fall progressively postpartum, both in the normal population and in women with von Willebrand disease. They are particularly at risk of secondary postpartum hemorrhage, so they should have education on the necessity of use of tranexamic acid at home, and when bleeding is heavy, how to contact their centre. Iron deficiency is highly prevalent amongst women with von Willebrand's disease, even prenatally and antenatally, so they are at risk of further iron deficiency postpartum, and consideration should be given to iron checks and supplementations if required. Women may have previously had heavy menstrual bleeding, and the return of their menstruation can be problematic. So the discussion regarding suitability for hormonal options, particularly if women are considering breastfeeding or not, is important to have early with the patient so they can plan accordingly. And all children who could potentially be affected should be linked in with paediatric services for subsequent testing and follow-up. So in conclusion, combined care from obstetrics and haematology with expertise in bleeding disorders is required for optimal management of pregnancy in women with von Willebrand disease. For every patient, we should establish the bleeding phenotype, the responses to past treatments, and third trimester plasma VWF levels in order to guide peri-delivery planning. We need to ensure clear communication with all those involved in care and that laboratory support is planned and available where needed. We also need to inform our patients about the importance of tranexamic acid use postpartum and the symptoms and signs of secondary postpartum hemorrhage. So we have a quick e-learning quiz in order to assess your interest in this area. In preparing a delivery plan with a patient with von Willebrand disease, which of the following is advised? So one of these is false. Which one? Should you involve the patient in shared decision-making? Should you include advice on neurotoxic anesthesia? Should you decide on the preferred mode of delivery? And should you advise on hemostatic cover? So in this, C is false. The mode of delivery should be determined as per obstetric indications, not by hematology. And with that, we conclude part 1 of this e-learning module. Please click on the link to part 2 below to learn more on this important topic.